Richard is 71 years old, a retired mechanic from Pennsylvania. For almost 4 years, Richard took his blood pressure pill every single morning with his coffee. He never skipped it. He never argued with it. He never thought twice about it. He trusted Dr. Clara Hoffman. He followed the instructions exactly the way he was told, and for a while nothing seemed wrong. But around 9 months ago, something started changing. His wife noticed that the man who used to wash the car, mow the lawn, and walk the neighborhood before sunrise was now sitting down after the smallest effort. He started saying things like, "I'm just not myself today." Then that became, "Maybe I overdid it." Then eventually, it became silence. He stopped taking the stairs unless he absolutely had to. He stopped going to the home improvement store on Saturdays. He told his grandson he was too tired to throw a baseball for more than a few minutes. One morning, Richard stood up from the breakfast table, took 3 steps toward the sink, and suddenly had to grab the edge of the counter to keep from collapsing. His wife checked his pulse. It was 48 beats per minute. His family assumed it was aging. They assumed this was what getting older looked like. They assumed his energy was simply fading because he was in his 70s now. But the truth that changed everything for Richard was this. It was not age draining his energy. It was his medication. Quietly, gradually, 1 dose at a time. And that raises a question almost nobody thinks to ask soon enough. Between Amlodipine and Metoprolol, which one is actually safer after 60? Because one of these medications is far more likely to leave certain seniors feeling exhausted, slowed down, and years older than they really are. And the answer is not as simple as most people think. Before I compare these 2 drugs side by side, I need you to understand something foundational. Because without this, the rest of this conversation will sound like just another medication debate. And it is not. The way your body handles blood pressure medication at 68, 72, or 79 is fundamentally different from the way it handled medication at 45 or 50. Not slightly different, profoundly different. And most people never get this explained clearly because routine appointments move too fast. Here is what changes. After 60, your artery walls begin to stiffen. They lose some of the flexibility they had when you were younger. That matters because stiff arteries push your systolic pressure higher. That top number becomes harder to control, and it is strongly tied to stroke risk, heart attack risk, and even cognitive decline over time. But it does not stop there. Your liver, which helps process many medications, may work more slowly. That means a drug can stay in your body longer than it used to. Your kidneys may filter less efficiently. Your nervous system may respond more slowly when blood pressure suddenly drops. And your heart itself can become more sensitive to medications that slow it down. This is the lens I need you to carry through everything that follows. A medication is not automatically safe just because it is common. A medication is not automatically dangerous just because it has side effects. Its real-world safety depends on the body it enters. And after 60, that body has changed. Let us start with amlodipine. Because if your primary problem is high blood pressure caused by stiff aging arteries, amlodipine often enters the conversation for a reason. Amlodipine is a calcium channel blocker. That sounds technical, but the idea is simple. Your blood vessels contain muscle in their walls. Calcium helps those muscles tighten. When the vessel walls tighten, pressure rises. Amlodipine blocks part of that calcium movement, which allows those artery walls to relax and open wider. When the vessels open, blood moves through with less resistance and blood pressure comes down. For older adults, that matters because amlodipine is working directly on one of the most common age-related problems, stiff arteries and elevated systolic pressure. This is one reason calcium channel blockers are often favored in older adults with uncomplicated hypertension, especially when the main issue is the pressure itself rather than a separate heart condition. Now here is the part many people are never told. Even when amlodipine is the right choice, older adults often need to start carefully. Why? Because elderly patients can be more sensitive to sudden pressure changes. And in small, fragile, or older patients, doctors often consider lower starting doses and then adjust gradually based on tolerance. That gradual approach matters more than people realize. Because when this medication is tolerated well, it can lower pressure effectively without directly slowing the heart. And that becomes a very important distinction once we start talking about energy. If this is already making things clearer for you, take a second to subscribe and type the word energy in the comments. Because now we need to turn to metoprolol. And this is where the conversation becomes very personal for a lot of people. Metoprolol is a beta blocker. Unlike amlodipine, which works mainly by relaxing blood vessels, metoprolol works by acting on the heart itself. Your heart has beta receptors that respond to adrenaline. When those receptors are stimulated, your heart beats faster and harder. Metoprolol blocks that signal. The result is that your heart rate slows down. Each beat may become less forceful, and your overall blood pressure may come down because the heart is not working as aggressively. Now, in the right person, that can be incredibly valuable. If someone has had a heart attack, if they have angina, if they have certain arrhythmias, or if the heart needs protection from excess workload, metoprolol can be exactly the right medication. In those cases, it is not just lowering blood pressure, it is protecting the heart. But here is the part that matters so much after 60. When you slow the heart in an older adult whose system is already more sensitive, the same mechanism that protects one person can drain another person. And that is why fatigue is one of the most common complaints people report on metoprolol. Not ordinary tiredness, a deeper kind of heaviness, a loss of drive, a feeling that the day starts ending before it even begins. Some people notice they no longer want to walk as far. Some lose exercise tolerance. Some begin taking longer naps. Some feel mentally dull, physically flat, and emotionally less like themselves. And when the heart rate drops too low, dizziness, lightheadedness, or even near fainting can start showing up. That is why metoprolol usually has to be started carefully, monitored carefully, and never stopped suddenly. That last part is critical. You must never abruptly stop metoprolol on your own. Stopping it too fast can trigger rebound effects, including a surge in heart rate, a spike in blood pressure, chest pain, and in some patients, serious cardiovascular danger. Now let us put these two medications side by side, because this is where people stop thinking in theory and start recognizing themselves. I want to tell you about Denise. Denise is 67 years old, a retired elementary school teacher from Arizona. She had been taking metoprolol for more than 2 years. Little by little, she began feeling older than she was. By early afternoon, she felt drained. By evening, she felt done. She told Dr. Clara Hoffman that it felt like someone had turned the dimmer switch down on her entire body. So Dr. Clara Hoffman reviewed her case and made a supervised change. She was transitioned off metoprolol carefully and placed on amlodipine instead. Within a few weeks, Denise felt a shift. Her energy improved. Her motivation returned. She felt lighter. But then another problem appeared. Her ankles began to swell. By the end of the day, her shoes felt tight. Her socks left deep marks. She told her sister, "It's like I traded exhaustion for puffiness." And that story captures the central truth of this comparison. Neither drug is universally safer. Each one has a different price. Amlodipine more commonly causes ankle swelling, lower leg edema, flushing, dizziness, and sometimes palpitations. That swelling is not usually because the body is retaining salt the way many people imagine. It happens because the blood vessels relax unevenly and fluid can pool more easily in the lower legs. For some seniors, that swelling is just annoying. For others, it affects walking, balance, shoe comfort, and confidence leaving the house. Metoprolol has a very different side effect profile. Its most common complaints revolve around slowing, slower pulse, lower energy, reduced exercise tolerance, heavier fatigue, dizziness, sometimes shortness of breath. And in certain people, especially those already taking other heart-slowing medications, the heart rate can drift lower than is safe. This is the moment where many families make the mistake that costs them months or years. They look at the fatigue and say, well, he's getting older. They look at the slower walking and say, that's normal at her age. They look at the afternoon exhaustion and say, maybe this is just what 70 feels like. No. Not always. Sometimes what looks like aging is actually medication mismatch. And now we enter the part of this conversation that I believe is one of the most overlooked dangers in senior care, because the real risk of either medication does not exist by itself. It exists in the context of every other pill in the cabinet. Most adults over 65 are not taking one prescription. They are taking several. A medication for blood pressure, something for cholesterol, something for reflux, something for sleep, something for pain, something for blood sugar. Each one may be reasonable on its own, but together they can change the entire safety picture. Amlodipine is processed through pathways in the liver that can be affected by certain other drugs, and even grapefruit can interfere in ways that increase the medication's effect in some people. That can mean more dizziness, more swelling, and a greater fall risk than anyone expected. Metoprolol carries its own interaction concerns. If it is layered with other medications that also slow the heart or lower blood pressure, the combined effect can become much stronger than intended. The pulse falls, the fatigue deepens, the standing dizziness worsens, and suddenly, a person who thought they were just slowing down is actually being overslowed pharmacologically. That is the word nobody says often enough. Overslowed. So what do the broader recommendations suggest? This is where the evidence becomes useful. For many older adults with straightforward hypertension, drugs like calcium channel blockers are commonly used as first-line options. Beta blockers, on the other hand, are usually not the first choice when the only issue is uncomplicated high blood pressure. They tend to make more sense when there is a separate heart reason to use them, such as prior heart attack, angina, heart failure, or certain rhythm problems. That distinction is everything, because it means the question is not simply, which drug lowers blood pressure? The real question is, why was this specific drug chosen for this specific body? If your main problem is stiff arteries and rising systolic pressure, amlodipine may be the more appropriate and better tolerated option. If your heart needs protection, if your rhythm needs control, or if your history includes certain cardiac events, metoprolol may be the more appropriate medication, even if it comes with a higher fatigue burden. That is why there is no honest one-word answer, but there is an honest, practical answer. If you are over 60 and your biggest complaint is that you feel unusually tired, flat, weak, or slowed down after starting blood pressure medication, metoprolol deserves a very careful second look. Not because it is a bad drug, but because in the wrong body, at the wrong dose, or for the wrong reason, it can quietly drain energy in a way many people mistake for aging. If this distinction is helping you, type the word clearer in the comments and stay with me, because this next part may be the most useful section of the entire video. Here are 5 questions I want you to bring to Dr. Clara Hoffman at your next medication review. Question 1. Is this medication being used mainly to lower my blood pressure, or is it also being used to protect my heart for another reason? Question 2. Based on my age, pulse, and current symptoms, is my dose still appropriate for me right now? Question 3. Could my fatigue, dizziness, slower walking, or reduced stamina be a medication effect rather than normal aging? Question 4. Has my full medication list been checked for interactions that could increase swelling, lower my blood pressure too much, or slow my heart rate too far? Question 5. If this medication is no longer the best fit, what would a safe supervised adjustment look like, and how would we monitor it? Those questions matter because they move you from passive patient to informed participant, and that can change everything. I want to take you back to Richard, the 71-year-old retired mechanic who nearly collapsed on the way to the sink, the man whose family thought age was quietly taking him away from himself. After that morning, his wife pushed for a full medication review with Dr. Clara Hoffman, not a rushed refill, not a quick blood pressure check, a real review. Dr. Clara Hoffman looked at the whole picture, his symptoms, his resting heart rate, his blood pressure pattern, his other prescriptions, his heart history, and the reason he had been placed on the medication in the first place. That review changed the plan. His treatment was adjusted carefully and monitored over time, and within weeks, the difference was noticeable. His pulse stabilized, his stamina improved. He stopped needing to sit down after every small task. He began walking again in the mornings. He went back to the hardware store. He played catch with his grandson without asking for a break after 2 minutes. Richard's story is not a miracle story. It is a medication matching story. It is what can happen when the right question finally gets asked. So let me answer the question you came here for as clearly as I can. Between amlodipine and metoprolol, which one is more likely to be slowly draining your energy after 60? If the issue is fatigue, low pulse, reduced stamina, and that heavy slowed down feeling, metoprolol is more often the medication that raises concern. But that does not automatically mean it is the wrong medication. It means it is the medication that deserves a more careful review. Amlodipine often fits older adults better when the main problem is uncomplicated high blood pressure driven by stiff arteries. Metoprolol often fits better when the heart itself needs protection. The safest drug is not the one with the best reputation. It is the one that matches your body, your diagnosis, your heart, your other medications, and your life right now. Your blood pressure prescription should never run on autopilot, and your energy level after 60 should never be dismissed without asking why. This video is for educational purposes only and does not replace the guidance of Dr. Clara Hoffman or your personal physician. Never start, stop, or change any blood pressure medication without medical supervision. If this helped you today, subscribe, turn on the notification bell, and tell me in the comments. Are you currently taking amlodipine, metoprolol, or both?